us for the winter night CPD event. Well, at the moment, just on housekeeping. If you're just joining us, can I get you to change your name to display the full name with your ODOB number for the CPD points? For any technical issues, we have William from ODOC. William will share his email with you if you face any trouble disconnecting during the process, so that he will be able to allow you to back in. Now, tonight we have two expert speakers there. Well, in eye care, we are on a mission to make the eye care scene much more connected. And so grateful to have so many of you joining us tonight, including ophthalmic nurses, dispensing opticians, optical assistants, optometrists, and ophthalmologists from all around the world. Right. So tonight's topic is about advanced IOL lenses, right? And our first speaker from Alcon is Ice Liu, who's a optometrist as well, talking about the current technology in the EDOF lens, the multifocal lens, and so on. And we're looking forward to hear all the advancements in technology. Then in the second segment, we'll have Dr. Hong, who will give us a run-through of realistic cases. So now let me pass on the platform to Ice Liu, who will present on the advancement in IOL lenses.
Everybody, can you hear me? Yeah, all right. I'm just going to get straight onto it. So welcome, everybody. I'm Ice. I'm an optometrist. I'm here to talk to you guys about PCIOLs and some pre and post-op tips on management for your cataract patients. And IOL, it's advanced a lot, as you may know recently, and you'll soon hear why it's incredibly important for optometrists to know and understand these advances so you can communicate your critical insight as optometrists, as this will help improve patient outcome. Please note, tonight's education is not about getting you to recommend a specific type of IOL to your patients. That decision must always rest with the surgeon and the patient. However, what we want to do is to help facilitate the flow of information between optometrists and surgeons and to improve the patient experience when they go on their cataract journey. The use of presbyopia correcting IOLs is increasing due to technological advances and increase in patients' visual demand and expectations. Nearly 1 in 6 IOL implanted across Australia and New Zealand is a presbyopia correcting lens. This means you're going to see more of these in your clinics, so you should be able to identify and refract these lenses. You should also understand the expected outcome of these and how to manage them in the community and be able to provide critical insights when you're referring them. Because not everybody will get a chance to hear about these different lens options, especially in the public systems. So what are the latest PCIOL technology? Traditionally, out of all the lenses, you're probably most familiar with the diffractive multifocals. These lenses, like the picture there, have concentric diffractive rings around them, and every multifocal lens is designed differently. Alcon's multifocal is called Panoptix, which provides excellent distance, intermediate, and near function that gives a continuous near to intermediate range from 40 to 80 centimeters, peaking at about 60 centimeters. So that's really important for you to know when you're doing your working distance. And remember the optics, diffractive lenses splits the light. So in this case, 50% of the light's going to the distance, 25% intermediate and 25 near, working on simultaneous vision at any given time. So you'll have one clear image and two blurry images at the same time, and the brain will select what to look at. As a result, glare and halos have quite common side effects with any diffractive multifocal lenses, especially right after surgery. So often, patients are carefully selected and counselled for glare and halos. Generally, well-selected patients will neuroadapt by about 3 months. They probably won't notice it, or they will notice it, but it won't bother them. Just like progressive glasses and your peripheral distortions. Technology and patient selection and counselling has improved to reduce these issues. These are available in torics to correct for your astigmatism patients because this is very important as presbyopia correcting lenses are sensitive to residual astigmatism. So traditionally we had both multifocals and EDOF lenses as diffractive lenses, which meant there's a risk of visual disturbances, glare and halos. About 4 years ago, Alcon launched the Vivity IOL, which uses X-wave front shaping technology, which gives patients the range of vision without them as much of the visual disturbances like a diffractive lens. With any lenses that correct presbyopia, compromises are made, such as with progressive glasses, bifocals, or multiple pairs of single vision glasses. This is the same with IOLs. When we're designing lenses, we're trying to create multiple focal points along the visual axis. So that's like in that blue cylinder. However, not all the light's going to be used. So the lights that's not being used that cause a stray light onto the retina, which is in that pink zone. And these are perceived as glare and halos by the patient. As previously mentioned, Alcon Vivity uses X-wave front shaping technology where the light is stretched and reshaped into a channel so that you get less of that stray light and that continuous range of vision. This way you can get reduced glare and halo symptoms for your patients. Our Vivity lenses give good intermediate and good distance vision and some functional near, but the patient will still need glasses for prolonged reading. So it's a great day-to-day functional lifestyle lens for your driving, buying food from the grocery stores, etc. As mentioned before, these are non-diffractive lenses, so it doesn't split the light. So the dysphotopsias and the glare and halo profile is less compared to a diffractive lens. And just like panoptics, you want to leave as little residual astigmatism as possible in these patients. And you can see there in the center of that picture, there's the X-wave technology. It's a very subtle 1 micron change, so it's invisible to the naked eye. In clinical trials 6 months after the surgery, binocular mean uncorrected distance vision was about 6.6, and at intermediate 66 centimeters was about N6, and near about N8 to N10. And these lenses work best with binocular summation. So here's a summary of all the different lenses out there and what they can deliver. And as we know with glasses and contact lenses, there's no perfect option for anyone. We have to assess their lifestyle, their expectations, and meet their needs, which is something that us optometrists do on a daily basis. So monofocal lens will give you good distance, but they will need glasses for computer or intermediate in reading, but with a low risk of glare and halos. With Vivity, it gives you good distance and intermediate, but they'll still need glasses for fine print and prolonged reading with a low risk of glare and halos. And with Panoptics, it gives excellent distance, intermediate and near vision, and probably the one that will give you the most spectacle independence, though we can't guarantee it, but it still has a higher risk of glare and halos. So now we've had a quick chat about different IOL technology. Let's talk about what our patients want. What's their perspective? We did some market research and looked at a large cohort of cataract patients and investigated what they think happened to their vision after cataract surgery. 33%, or 1 in 3 patients, expected not to wear glasses. And they don't know anything about cataracts, how it works or why. That's just an underlying expectation. And about 14% think that they only need it for near work, like sitting down to read, not things like looking at the phone, your dashboard, and general middle view. So potentially nearly 50% of your patients will be disappointed if the expectations are not met and they don't understand the options available to them. As a healthcare provider, we use clinical measures to gauge success. And there are good reasons for that. That's what we are taught. We want to make sure that there are no complications after surgery and that the refractive subjective outcomes are great and that the Snellen acuity is at 6.6 or better. But patients are more likely to gauge the success by looking at the clinical outcomes impact on their day-to-day life, such as catching the bus or being able to drive, being mobile around the house, or being able to see their phone and tablet. So those aspects is going to be different to our expectations. So it's important for clinicians to understand the patient's values in order to align their refractive target to their expectations. Sometimes their need may be unstated. We almost need to preempt what they might expect, such as your myopes who can read fine without glasses, and sometimes post-op, if they can see great distance but they've lost the ability to read, they can still be really unhappy. We also have patients that can see great at all ranges of vision, but their eyes might not feel great. So for them, is that a successful surgery? onto the clinical pearls. So in a typical patient coming in with cataracts and you're referring them for cataract surgery, it would be really helpful to include things like their visual demand, hobbies, occupations, specific needs such as jewelry making, needlework, cooking, etc. Something that we ask in their history on a day-to-day appointment. Obviously, the other thing we want to look at is their history to adaptation to glasses. So how much remakes have they done? Are they used to, their refraction? Have they got prisms in their glasses? And also include their intermediate and near vision. History of their contact lenses. Have they worn multifocal contacts before or monovision blended contact lenses? Dry eyes is really important. Are there on any current dry eye treatments? And most cataract patients these days are in that age bracket where they will have a compromised tear film, which is going to impact on their biometry and measurements that helps determine the power of the lens and subsequently the outcome of the patient. Got to remember also post-op, the dry eyes peak at about 4 to 6 weeks. So it's really important to have those drops prescribed for them in that continual flow of management. Glare sensitivity, are they worried about glare and halos, or does the desire of glasses independence outweigh this? And ultimately, all these information needs to be passed on to the doctor so that they can make a suitable decision with their patients. I don't know why I have a red line there, but we'll keep going. There are little different resources that we can provide, such as health questionnaires, and we've also got this online website that can look at simulating different types of lenses, just like with glasses, like bifocals versus progressives versus single vision. That's something that you guys can email me. I'll leave my email at the end if that's what you want for your practice. And really what we want to do is give patients a head start to think about what they use their eyes for, because ultimately they've only got one chance to do their surgery and we want them to be prepared. Now that the patients have had their surgery, they've come back to you 4 weeks post-op. And if you don't know what lens they may have a presbyopia correcting lens. Make sure you check for the different optics, as it's going to change how you refract and prescribe the glasses. If you use duochrome, try to use something else because it might give an off reading because of that simultaneous distance and near vision. If you use your autorefraction, which most of us do, try not to rely on that because it's going through the central portion of those lenses, which is often the intermediate or near range. Make sure you use subjective refraction to push plus and check unaided vision for distance, intermediate and near binocularly, and that'll give you a good indication if they've got a presbyopia correcting lens. So if you have got a multifocal or trifocal, they might have good distance and intermediate binocularly, and if you have good intermediate but not so good near, then they may potentially have an EDOF. And then when you move on to your slit lamp, if it's a diffractive lens, it's easy to see because then you can see it as a, the diffractive rings. But with vivities, it can be a bit more challenging. We always do recommend to dilate the pupil if you want the best view. As you can see in that video, even when it's dilated, if you're looking at it head straight on, it's really hard to see. So the best view, I think, is to do on retroillumination. So if you can see there, that subtle change there, that's the X-wave technology. If you've got someone who is undilated, excuse that red line, but if you see that undilated, you can still see it if you play with the light a little bit to see that subtle change there, right there in that center. One of the surgeons recommended to look at cobalt blue filter, which makes it easier to spot these lenses. Right, so refract, like I said, check your vision first binocularly for distance, intermediate and near. That should give you a good indication if the patient's got a presbyopia correcting lens or not. Don't use your autorefractor. Perform a subjective refraction by pushing plus and just sanity check your results to make sure it adds up. If you got an EDOF or extended depth of focus lens, you probably only need to add about a +1 to 1.5. If you give more, patients will like it, but as you know, that will just reduce the working distance and increase the magnification. What else do we need to consider when we're managing the patient if they're not happy? Obviously, it's really important for us to be reassuring to the patient before jumping to conclusions and planting seeds of doubt. We advise patients make a big difference to them between soldiering on to a point of adaptation or feel like everything's turned into a disaster and they want to take the lens out. A panic patient doesn't help you or your patient or the doctor, so it's really important. Despite what your opinions might be, it's best to just support them through that post-op journey and stay communicated with the surgeon. Neuroadaptation is quite a key point, and just like glasses, some patients take longer to get used to their progressives. A lot of clinical data on the IOLs actually publish at 6 months, so giving patients time to settle, and that's really important. And that's similar with the glare and halo awareness. It's normal to notice the glare and halo sometimes, but they will notice it less, and they will become less bothersome with time. You also got to remember, nothing will give them the vision when they were in their 20s, so it's not a perfect shoe to fit everyone. Review the expectation, focus on what they can see with both eyes. If they're shutting one eye, it's never going to help them, going to struggle to neuroadapt. Remind them about their forgotten expectations. You can show them the differences. If they can read with their multifocal, show them with a -2.5 in front of them and take that reading away, or a 1.5 with an extended depth of focus lens to make them lose their intermediate vision. Demonstrate that difference to remind them what they have. There is no free lunch, so to get one thing, there will be a bit of compromise in others, but just reassure them and get comfortable with their IOLs and give them time to get used to things, just like with progressive glasses. And you can always refer them back to the surgeon if you need to. And don't forget to check for other health issues, starting anteriorly, working posteriorly. You want to make sure that the dry eye is looked after. Remember that dry eyes gets worse before it gets better. And remember, they're on a lot of topical medications for post-surgery as well, the impact of that on the tear film. Also looking at the PCO, patients often can be delighted by their vision at the start, and then the VA drops. And that can have different impact. Presbyopia correcting lenses have relatively, if you have small amount of PCOs, they can affect the complex optics of the multifocals and EDOFs. And don't just stop at the first thing that you find that could be impacting the vision. Make sure you check the back of the eye as well for things like CMO. That's it. That's my email there. Any questions, feel free to pop me in the chat or email me if you want resources. I did have examples, but we don't have time. So we do run webinars as well throughout the year to discuss case examples, but feel free to contact me if you guys need anything. Thank you.
Thank you, ICU. Just mute. Back. Unmute. Thank you for putting up with technical difficulty. It's definitely worth a wait. The question from Sheng online, sir, is there an Alcon multifocal contact lens with similar optics to help gauge the acceptability before surgery?
It's a great question. Unfortunately, there isn't, because the multifocal contact lenses work by refractive technology and lenses are diffractive. So the optics are completely different. And I understand the need to kind of try and simulate as much as we can. Maybe one of the smart educators, the link that I have can help with that. If you email me, I'll be able to send you that link and we can talk through that. But no, there's no contact lenses that can simulate that at the moment, sorry.
Thank you so much, sir. I guess just a reminder to all of our participants and welcome some of our new entrants. Feel free to use the chat function if you have any question for ICE. Okay, great. Okay, I guess now if you have any other question, just like I said, sir, feel free to email her. We'll leave the email in the chat as well. Then we'll move on to our next segment of the evening, sir. Joining us, we have Dr. Hongchen Chong, who's a ophthalmologist from the Odox Eye Care, and he will go through some of the live real cases of advancement in IOL, sir. So I will pass on the platform to Dr. Hong.
Thanks a lot, Tian, and thank you Ice. I think we have to acknowledge that this talk would not be possible without Tian's involvement. He's the one behind organizing all the CPD points and putting it through the website stuff that I've got no clue what to do. And thank you, William, for organizing the event and having the space available to speak. Again, the event is not sponsored, but we do have Alcon Ice Liu, who has kindly given up her time to prepare for this talk as well. So thank you again, Ice. Now, I'm just going to share my slide. But before I share my slide, sorry, I just thought that the smart educator that Ice was talking about, in case if you would like to see what it looks like, this is quite a useful tool to educate patients. You can slide it sort of back and forth. I do use it quite often in the clinic, especially when patients can't get the idea of exactly what is a multifocal versus an EDOF versus, a trifocal lens. And you can even simulate daytime or nighttime, and the whole idea of doing that is so that you can actually show them, what you meant, by the unwanted glare and halos. And you can even set, the degree of the symptoms, from mild to severe, moderate. So that's a very good tool in case if you're wondering, whether the patient is sort of, taking what you're saying on board. Now, I'm just going to move back to my slides. We've got a very tight schedule and we've got quite a lot of contents to cover. So we'll take questions at the end of my session. I'm based in Dunedin, so I work at both public hospital and private. I mean, this is the $1.5 billion project, which we're still hoping that we're going to see one day soon. But this is what we have to settle with at the moment. It's not too bad. We're functioning. I have no financial interest in any of the lenses or the technology that we talk about in this talk, but I do have a private practice in Dunedin, and I operate at Mercy Hospital. I've got a new practice coming up in Queenstown. Hopefully, it'll be operational by the end of August to serve the Central Otago community. Now, principles of cataract surgery, I think just like principles of medicine, first, do no harm. Not everyone has to die, pseudo-phakic. I know Ben Lahoud is quite famous in this term, no one should die phakic, but I think go back to the basic principles of, first, do no harm. Not everyone requires a surgery. We only do surgery if it's necessary. And cataract surgery obviously requires, adequate anesthesia, and the age of modern anesthetics has improved so much that these days we can do a lot of surgeries just under topical anesthetics or subtenon anesthesia. Less than 2% of my patients require general anesthesia, primarily for things like severe anxiety or medical reasons. They've got tremors, Parkinson's, where they can't control the tremors even when they're resting, or, patients with Down syndromes or issues following commands, and obviously younger patients. Now, and obviously the next bit, which is to remove the cataract, the cloudy lens, we want to clear out the visual axis, preserve the capsule. That's where we're going to put the lens in. Preserve the zonules that holds the capsule. We need to protect the cornea endothelium. When we use phacoemulsification, what happens is the phaco itself is like a jackhammer. It creates a vibration that is actually adverse to the health of the endothelium. So therefore, we use things like viscoelastics to protect the endothelium. We try to minimize the wound size. In the past, cataract surgery used to be a good 8 to 10 millimeter wound size when they were doing it, the extracapsular approach. Nowadays, even as small as 1.8 millimeter wound size can be achieved. Typically we do about 2.4. And after surgery, it's important to monitor for potential surgical complications, even though the risk of complication these days are getting very, very low. And then optimize post-operative vision. I mean, ultimately, we want to make people see better. And so for those who have not observed a cataract surgery before, this is essentially what a cataract surgery is about. This surgery was done under topical anesthesia. And you can see the first step is to make the wound, and then a little capsular needle to create a capsular opening. We call that the continuous capsular rhexis. And ideally, the size would be about 5.5 millimeter, then hydro dissections and hydrodelineation. And then that's the phaco, creating a little scalp in the middle, and then crossover with the cross. This is what we call a divide and conquer. And then with the phaco probe, you take up the rest of the cataract. And you've got this residual soft material called the cortical material and epinucleus that can be removed with the irrigation and aspiration probe. Viscoelastic is then injected into the eye, and then the lens is then injected into the bag. And make sure that the lens is well positioned, and the rest of the viscoelastic is removed, and the wound is just hydrated with fluid. There's no sutures required, and antibiotics and steroids was given at the end. And obviously the surgery was, times 4 or something like that. And typically a cataract surgery, including the anesthetics, is usually under 15 minutes. Now, I'm not going to go through what Ice has talked about in terms of the IOL technologies that she's mentioned for the presbyopic correcting IOLs, which includes the EDOF. But I will be talking about some of the other IOL technologies available and arsenals that we have as surgeons and for our patients in various situations. And I talk about, the recognizing some of the EDOF. And one of the easiest, EDOF to recognize is the Alcon's Vivity, and it's also one of the most popular EDOF implanted around the world. So I think as an optometrist or, our healthcare professional, I think it's important for us to be able to recognize this. And using the red reflex, as I mentioned, that's one of the easiest way to pick it up. And then there is some of these that does not alter the surface of the lens as visible as like the Vivity. Some of the lenses nowadays, they call themselves the EDOF lenses, play around with things like aberration. So you've got lens like the Luxmart that plays around with the 4th and the 6th order aberration to try to elongate the focus center to create, a much sort of a slower decline in the transition zone. And this is one of those things that they use, MTF to measure, how much defocus curve that you can give the patient, a range of vision. Obviously, this is just an optical test, does not always translate to actual function in patient. And this is one from Rayner that uses, controlled positive aberration. In some ways, when we heard about aberration, it always sounds bad, but when it's a controlled aberration actually gives, a wider range of vision. And so by using a controlled aberration, this lens could give a range up to about 1.5 diopter. One of the downside with the Rayner EMV lens is that it is hydrophilic. So I do use them often, but not in every single case in patients who opt for an EDOF lens. The issue is obviously with hydrophilic lenses. If you're using it in patients who may potentially require future procedures, such as an endothelial keratoplasty or a retinal surgery that would expose the lens to air or gas, and there is a potential problem with the lens becoming opaque. And then lately, there is also the POC from Johnson & Johnson that alters the curvature of the lens posteriorly to elongate the vision. These lenses are quite hard to actually know if they are EDOF or not on the slit lamp because there are no subtle signs for you to tell. So the answer is it's almost impossible for you to identify these EDOF on the slit lamp unless you check the intermediate near vision and distance. And the pupil size. Obviously, some of these lenses actually work much better if their pupil size are smaller than, 3 millimeter in general. And so that's just a defocus curve to show you that the ZEN00V is the POC defocus curve compared to the ICBOO or ZCBOO. These are monofocal lenses. And then there is also another technology that actually splits, the lens into 2 segments, almost like a bifocal lens. When I talk to my patient, instead of calling them EDOF, it's just very confusing. I just say, right, you want the monofocal, the bifocal, or the trifocal? And this is practically a bifocal intraocular lens that's got 2 segments. It comes with a at 1.5 or a +3. At +3, but the issue with the +3 is sometimes you get this angel wing phenomenon when they look at a light. Looks like there's a split of an angel wing coming above. So that's one of the dysphotopsia of this lens. You often get that more in the higher power, which are +3 reading segment compared to the +1.5. So I've not put in +3 unless it's an Asian patient who love looking up close, when they've always been mildly myopic. And then there is also the, diffractive plus, surface curvature altering lenses like the tetanus IOL. One of the issues with these lenses is that it also uses diffractive technology, and I've already talked about one of the few problems such as, degrading images, glares, and halos. So if I were to put in, diffractive technology, I might as well use trifocal and not use, something that mixes both. So the question is, who's an ideal candidate for some of these PCR? I think patients who have got no ocular pathology, they've got no corneal problems, retinal issues, glaucoma, healthy eyes basically in general, and they do, have a desire to be a bit more spectacle independent. These are the ideal candidates. Obviously there's an additional cost to it. Some of these PCRLs are not, well, actually all of these PCRLs are not available in the public sector. And that means, patient will have to foot the bill. And none of the insurance provider would actually pay for premium hours as well. Most of the insurance will only cover the cost of the basic monofocal lenses. And this tech is obviously not for everyone. Patients who've got pathologies that I've mentioned early on, they're definitely not a candidate. And especially with the trifocal lenses, if you've got the smart educator that you can show them, and they say, oh, no, I just don't like the idea of having any of these, glares or halos at all, then, you've identified a patient who is not a candidate for those things. And especially in New Zealand, because, we rely a lot on driving around the place where our public transport system is near non-existent. It's actually quite a very small selective cohort of patients that I would put them in, especially if they tell me that, oh, I intend to drive, from Dunedin and Wanaka at nighttime after work every week. I'll be, oh, well, you're not a candidate. I would offer you a trifocal lens. Now, other than those lenses that we talked about, the next category is a pinhole intraocular lens. When the IC8 was introduced, it was actually designed as a presbyopic correcting lens as well, just because, if you test someone's vision, unaided, corrected, and then you do a pinhole vision, sometimes you see a lot better. Essentially, this is the same principle, optical principle, using a pinhole within the lens. So it has an area that basically blacks out the lens, and it only has a 1.36 millimeter aperture centrally, and it corrects, up to about 1.5 diopter of corneal astigmatism as well. So one of the downside about this lens is obviously, making a pinhole within the eye sounds good, but like any other pinholes, you're reducing a lot of light going to the eye. So overall brightness, contrast may degrade, especially when they enter from a bright place into a shopping mall, or, going into a dark room, or at nighttime, which is why it is only recommended that, if we were to use a pinhole lens for the purpose of presbyopic correcting, features, we should only be doing it in one eye, and it should only be in the non-dominant eye. And this is what a pinhole IOL looks like, the IC8 on the slit lamp. You can see that little segment there. Obviously, you have to check what's the baseline patient's pupil. With their pupil tonically dilated, it's not going to work. Typically works, in pupil size between 2.5 to 3 millimeter, and that's where the black sort of zone covers the area. Sometimes it makes it a bit tricky, for patients with retinal pathology and stuff like that. So if someone has got retinal problems and things, it's probably not a good idea to put this in, because otherwise the retinal surgeon will be, cursing you. And in my practice, I think the pinhole IOLs doesn't really have much of a role, for presbyopic correction. But it does have a huge role when it comes to other pathologies, such as patient who has previously had radiokeratotomy. These patients, fortunately, are getting, rare these days. No one's doing RK, routinely anymore, since lasers and LASIK, excimer lasers have been around. But sometimes you still see them, especially if they come from other countries, had it done, 20, 30 years ago. The problem with RK is that it has a very unpredictable, corneal refraction. They usually get very irregular astigmatism. The power may be unevenly distributed, superiorly versus inferiorly, as you can see in the pentacam scan here. The pinhole IOLs basically is a great way, to try to bypass any of that corneal aberration and irregular astigmatism. And so here I've got a case, of a bad cornea. This patient has had granular corneal dystrophy, had PTK done in both eyes, over 20 years ago, had very irregular corneal astigmatism, and she usually wears a contact lens. She's practically a contact lens wearer, and with the contact lens, it's caused quite a bit of cornea problems as well, including Salzmann nodule. And her best corrected visual acuity has never been, better than 6/12, and now it's getting worse. She's got cataracts in both eyes. And this is the pentacam scan. So for those who are not familiar with pentacam scan, we look at the corneal topography. That's the anterior curvature power. This is the cornea thickness. You can see her cornea is extremely thin, isn't it? 214 centrally. Whoever did the PTK basically burned half the cornea in order to try to get rid of the granular dystrophy. And you can see that that's the anterior curvature elevation and posterior elevation. So not a very good cornea. The overall average corneal power is only 36. Normal cornea power should be somewhere between 40 to 44. Very bad cornea. And this is the other eye. You can see that her other eye has got similar problems. A lot of the cornea has been burned away. And she's got a little Salzmann nodule centrally, in that area. This is a cornea, not exactly hers, but her cornea look almost like that, despite having that massive PTK done, she still get, tiny residual granular dystrophy, but it is clear enough to the point that she's able to see out of it and that she's not keen in things like cornea transplant. So my options, would be to either, put in just a straightforward lens or to consider something like a pinhole IOL lens. And that's exactly what I did. In the right eye, where she's had a very low power cornea, I've given her just a simple monofocal lens, and she was quite happy with the 7.5 vision. With the left eye, I've put in a pinhole intraocular lens. But the problem is, these talks are interesting because there's no point in talking all about the success cases. This is one of those cases where I think I'm quite smart to put a pinhole lens, but ended up being stupid, because what happened is the eye that I've put in a pinhole lens, which is the left eye, is telling me to put in, a lens of about 25 diopter. And when we do things like pentacam scan, one of the features that we can look at is the EKR 65 to look at the power of the cornea at different zones. And you can see that there's a big difference. This is the left eye. You can see within the central 1 millimeter zone, there's like a 48 diopter power mean K versus the 4 millimeter or 4.5. Typically, we use the power from 4 millimeters or 4.5. But this is a warning sign. You can see that in this topography here, that high power right in the middle was actually from the Salzmann nodule. And whereas this is the other eye, you can see that, the cornea in the other eye is so flat. It's burned out so much that the central cornea has got, less than half of the normal cornea power. And as it goes towards, 4 to 4.5, this is the kind of mean power that we're getting. So because I did the right eye first and I got such a good result, and I was like, oh, well, maybe I should stick with, just using the power from 4 millimeters, given that there's such a big difference. And she ended up, this is the surgery. So she ended up having a -4 diopter outcome in the pinhole eye. And that's because she's seeing through that little Salzmann nodule. And so my plan is subsequently, once she's settled down a bit more, is to send her out for a laser, PTK, to try to get rid of that Salzmann nodule. But this is basically a pinhole intraocular lens being put into her eye. Now, now when it comes to, so when it comes to pinhole intraocular lenses, the one that you saw early on was primarily designed as a primary implant. So if someone has already got a problem that you're planning to put one in, you put an IC8 in. But if someone has had a monofocal lens put in and represented, 6 months, a year, 20 years later, and just say, my vision is just not great. I've had RKs done in the past, but I just can't see very well. Then there's also the sulcus pinhole lens option. So that basically means it's like a little piggyback that you put it into the sulcus space. So there's already a monofocal lens in there, and then you just put a sulcus lens on top of it. So this is one of those sulcus lens and what it looks like on the slit lamp. One of the sad things about the sulcus lens is that Morcha no longer have it as a registered product. So I still use them, but it's only on a case-by-case basis because it needs to be approved by MedSafe, and you can only order one lens at a time. So these are also great for irregular corneas, cornea with irregular astigmatism. Now, talking about add-on lenses, there's a company called First Q that they've got plenty of these lenses that you can add on into the sulcus. These are extremely well designed for correcting refractive surprises. I'm not talking about, 0.5 to 1 diopter refractive surprises. I'm talking about, something like 3, 4, 5, 6 diopters of refractive surprises in cases where lenses were selected incorrectly and the risk of a lens exchange is too high because, the capsule is already fibrosed or, the surgery was done ages ago. So you've got something like a 4 haptic placement or a 2 haptic. This is called a sulcus flex from Rayner. and that's the add-on IOL from First Q. They even come with toric corrections. You can correct any residual toric powers. The range, is +10 to -10. And for patients who has had monofocal lens put in the past, but have decided that they actually wanted, diffractive technology like a trifocal, there is even a trifocal add-on that you can go for as well. And so this is just a little surgery to show you. This patient is unfortunately had a same first and last name, but different NHI and birth date, but her biometry is acquired under, well, her name was actually used to acquire a biometry from someone else. So it was almost impossible, from a preoperative and operative perspective to identify what lens she should be using. And obviously she ended up, having a refractive surprise of -9. And so to correct that, you have the option of taking out the lens or put another one in, or to put an add-on lens. Given her zonules and the appearance of the lens and the capsule, I've decided to use the less risky way. She does have a lot of AC space, so putting an additional sulcus lens is not harmful. So I've decided to put on an add-on lens into the sulcus to correct that refractive surprise. So you can see that's practically making a wound size similar to a cataract surgery, injecting the add-on lens, into the sulcus space. So that two little advancing haptics needs to be placed right into the sulcus. And once it's in place, the other trailing haptics, the other two, can easily be tucked, into the sulcus space as well. And then the rest of the viscoelastic will be removed, and the surgery gets concluded just like any other routine cataract surgery. And this is the scan of the anterior segment scan of the patient's eye after surgery. You can see that's the primary intraocular lens right here, and this segment here is the add-on lens. Some of the few problems that an add-on lens can happen is missizing, mischarging the size. In a very small eye, you might get a big anterior vault causing things like, UGH or raised pressure in the eye. And there's another add-on lens that's been designed for patients with severe macular degeneration. So someone who has got poor vision, very poor vision, I'm talking about sort of worse than 660 or 690 kind of vision in one eye, and visual impairment in the other eye. So the better eye should be a vision somewhere between 612 and 636. These patients who are struggling with their reading vision, who always require a handheld magnifying lens, nowadays, you can put in basically a mini magnifying lens into a pseudophakic eye in that situation. This is the SML lens from the same company, First Q. It's got a +10 add-on addition, and you can add it on into the sulcus, just like the last video. And that would enable the patient to see and read things close up. So instead of holding a magnifying lens, they would just have to hold the books or the object of interest up close. One way to test that to see if your patient is suitable for it is to use a +6, lens, just trial lens in front of the patient's eye, and try to get the patient to read the books or the text that they usually read and find out, if that actually makes any difference. It does take a bit of time for the patient to get used to, and you shouldn't be doing this in patients with pupil size of less than 2 millimeters at baseline, just because that little magnifying lens is just right in the middle, and if their pupil size are way too small, it's actually going to degrade their distance vision. And the next in line is light adjustable intraocular lens. That's been around for, over a decade now. Unfortunately, still not in New Zealand yet. It's just haven't found its way here, primarily we're such a small country, from a commercial perspective. So LAL, or light adjustable intraocular lens, is a very cool technology. It's basically a lens that can be implanted at the time of surgery, and then the power of the lens can then be tweaked later on to lock in the refraction. So if you look at the studies, major studies, like these ones, where they looked at, 28,000 patients from 100 clinics, 27% of patients failed to achieve the refractive aim within 0.5 spherical equivalent. So in some ways, you have to tell your patients in cataract, in your clinic, and say that if I were to put a lens in your eye, there's a 1/4, a quarter chance that I'm not going to hit the exact target that I want, within the 0.5 spherical diopter. But that's still generally pretty functional vision. I would tell the patients, usually you get a pretty good, 90% vision, but it may not be 20/20 or 100%. And if that's bothering you, you may have to refract, your eyes and have proper prescription glasses later on. But with the LAL technology, after adjustment, 92% of patients will within the 0.5 and 99.5% of patients will within the 1 diopter range of the target refraction. So with the LAL technology, it has actually revolutionized, the way we can deal with refractions, during cataract surgery. And this is a 3-piece lens. The lens is not like the other acrylic lenses that comes in 1 piece, primarily because you need the haptics to be stable and not affected by the UV curing phase. And therefore, this lens is actually quite stiff when it gets injected into the eye. How it works is basically it's got silicon macromers that are sensitive to UV light. And the surgeon or the practice would have to have one of these machines to be able to send a specific, wave form of light into the zone that they would like to treat. And so, for example, this is a hyperopic correction. So if the patient needs to, add more power into the lens for hyperopic outcomes, unexpected outcome, I should say, you basically shine that UV light into the center part of the light, into the lens, and that causes the macromers to actually swell up, causing it more powerful to make it more myopic. And for myopic corrections, you need to reduce the power of the lens. So therefore, you shine more light into the peripheral zones of the lens to reduce the power. And so this is one of the cases that was published, a patient who was a high myope, had an uneventful surgery with LAL, but a week after surgery, vision was 675, satisfactory. And at day 14, vision started declining to 612. And therefore, at the clinic, they've done the UV irradiation to try to correct the refractive error based on that refractive error that was measured. And that's the UV being done. But then 1 week after that, the vision actually went worse, declined to 675. Refraction was even worse. On the slit lamp, they actually saw a paracentral elevation in the lens. And then eventually on further questioning, patient admitted that they should not use the UV protecting glasses at several occasions and expose herself to sunlight. This is one of the downside of having an LAL. And I think it's one of the things that is quite, impractical, because you do have to go out there and have some of these glasses on all the time. That's the lens, from the patient through that pupil that was exposed to the UV light from the sun. And therefore she got this sort of swelling of the lens up, causing that unwanted shift in power. And so these are the kind of lenses, even indoors, sometimes bright indoors, you need to use the less tinted ones. And if you're in the outdoors, you've got to use that. Typically, patient have to wear up to 3 or 4 weeks before they can go off the lenses. So it's not, a technology suitable for everyone. And even at that stage, most of these lenses offered are just monofocal lens. You're only talking about monofocal lens that are adjustable. Even though nowadays they've got a LAL plus, it's so-called the EDOF technology, but there's not a lot of results available yet. Now, aphakia, how do we treat aphakia? We can treat it from the front of the eye or from the posterior chamber of the eye. From the front of the eye, you have the anterior chamber intraocular lenses. And we've got the other one, which is the iris clip lens. But the biggest problem with these lenses is that they are very close to the endothelium of the cornea. So patients with anterior segment lenses comes with a 20 to 30% chance of corneal problems. And so it's not uncommon that you get patients, who ended up having corneal decompensation. Here in this case, this patient had a penetrating eye injury and the cornea has got, completely decompensated. So you can see that I've implanted a iris clip lens. Instead of clipping it to the front of the eye, because I don't want it to be touching the cornea, I clip it retropupillary, so just behind the iris. So we talked about the problems. And now scleral fixation is actually great because it's got similar sort of lens position to the natural lens. There's several options available, including suturing it with the Gore-Tex sutures. You can have what we call the Yamani technique, using these haptics and putting into scleral, or the color valid lenses. I'm not going to bore you with the details of the surgery, but these are some of the options available. Why would one choose one or the other? The all comes down to whether the surgeon's been trained for those procedures, whether the patient has got glaucoma. If they do have glaucoma, you don't want to be touching, some of that conjunctival and the sclera of the patient. This is another option available. Patients who have got trauma and loss of irises, and they may need, artificial irises and things like mortual lenses. Here's a patient who is a TV presenter, had a penetrating eye injury with a very bad cataract and loss of iris. And you can see here, I'm going to skip the video a bit quicker. We basically removed the cataract, and then we put in an artificial iris that's matched to the color of the other eye. I mean, you can technically just do the cataract and not fix the problem with the iris, but then the patient will have severe glare and poor vision. And so in this video, basically I have to find the iris to the size that I want, and then put it into a little injector. And once it's folded into the injector, that iris can then be injected into the patient's eye within the bag. So you can imagine, like a normal cataract surgery, when we remove the interior capsule, you've got the rhexis, you just have to inject that little artificial iris into the bag. And that's what it looks like towards the end of the surgery. And that's day 1 post-surgery. You can still see that he's got that sort of corneal wound from previous penetrating eye injury. And picture here is 1 week post-op, base corrected visual acuity of 624. And this is 9 month post-op. You can see that his eye color is actually looking pretty normal. No one actually, you could tell that there was an artificial iris implanted in that eye, and he's seeing 612. And here's another case, with trauma, previous graft, unfortunately lost her phakic lens. And this surgery here shows you that when basically putting in a mortual lens. And like I say, this is not an option for patients with glaucoma and stuff, because it does require, us touching the actual sclera and the conjunctival. But that's a mortual lens that comes with a lens with the power, and it's got this area that is blacked out to prevent unwanted glare. And the whole idea is that I'm doing a corneal transplant and the sutured mortual lens at the same time, so fixing both problems at the same time. The original cornea gets removed, and that little lens gets stitched up with the Gore-Tex suture and gets pulled through. So you can see that lens going in. Once it's in the correct position, that Gore-Tex sutures get tied up on both ends, and then I do the transplant at the end. And so she was, light perception in both eyes before surgery, and she had the same problem in both eyes, had to fix it one at a time, and eventually gave her an unaided visual acuity of 630, and that's basically her eyes on the slit lamp. You can see that she's got a new cornea, she's got a glaucoma tube there as well, and she's got an artificial iris with the lens power built in. So she's extremely excited. Now, when it comes to special cases, we've got things like corneal problems, Fuchs endothelial dystrophy. Patients with Fuchs and endothelial dystrophy, when they do have cataract, it's always a long consult to ensure that they understand the risk of corneal decompensation. And eventually, if they do end up needing a graft, you would expect a hyperopic shift. So choice of intraocular lenses is quite important. Typically, I would go for a hydrophobic acrylic lens. As I've mentioned earlier on, if you put in a hydrophilic, they may end up with a lens opacity. And if they do end up needing an endothelial keratoplasty, like a DSEC or a DMEC, you would expect that they will have a form of a shift. So typically, that's the shift you're looking at a lot more with the DSEC. This is a patient who's already had a cataract surgery, but ended up with corneal decompensation, and you can see that I've performed a DMEC. So nowadays, it's kind of tricky for you to see what DMEC looks like. It almost looks like a little LASIK flap, but at the posterior part of the eye, because the tissue is so thin. And that's a little flimsy tissue, and that's day 1. You can see the cornea is extremely swollen up, and that's at 4 weeks after surgery. Almost looks like a normal cornea. If you haven't actually looked properly on the slit lamp, you might miss a patient with DMEC. And that's what a patient post-DMEC looked like. You can't really see the graft itself, and that's just a single tiny wound suture that will be removed. And that's his other eye, with a DSEC. So unfortunately, this was his good eye in the past, but after he's had his DMEC, his good eye, so-called good eye, is refracting to 6.9, and his DMEC eye is refracting to 4.8, and now the other eye is becoming his favorite eye. Now, in eyes with previous graft, especially PK, after cataract surgery, there's a high risk of graft failure. So I always tell the patient that if we're going to have a cataract surgery in an eye with previous transplant, expect 50-50 outcome that, the graft may fail, and the refractive outcome can be unpredictable. So in here, this is a patient with a cornea that is decompensating. He's got a previous penetrating keratoplasty, and you can see that the cornea thickness is extremely high at 688, normal cornea thickness about 550. And you can see here is the OCT scan of the cornea. The cornea is not looking very normal. It's previous transplant done 20 years ago. And the problem is he's also got a cataract. So I actually did the cornea transplant first because I will not be able to see the cornea clear enough in order to do a cataract surgery safely. And that's a DSEC on top of a previous PK. You can see there's a little bit of an interface fluid, which I just have to add a little bit more air. And so after adding more air, and this is sort of a month after surgery, you can see that his cornea has got a lot clearer, and then I could go in and do his cataract surgery safely. And I think this is a much better approach to figure out what's the refractive outcome. And some of these patients would have very big, residual astigmatism. And so therefore, doing an add-on lens at a later stage, is an acceptable thing. And so that's the eye after the DSEC in a previous PK. And his other eye is actually pretty bad, So one of the things that we can do is to actually get an S-map scleral lens. So while he's waiting for the other eye to be done, because his other eye also had a PK, I was quite fortunate to have an optometrist locally who's got access to the S-map scleral lens. And imagine, a bad cornea that is so steep like that, he's able to see, 6.75 out of that eye. So I think Tian was saying that we've only got less than a minute to go. Is that correct?
Yep.
Okay. So at this stage, is there any questions that others would like to ask?
Okay.
Sorry, which one?
Yep.
Any tips on checking posterior with patients with pinhole? Yeah, so the question that was asked here is, any tips on checking posterior segment or the posterior pole for patients with pinhole intraocular lenses? The answer is you have to dilate them. They have to be dilated well enough so that you can see through the parts of the IOLs that have got no sort of black pigments. And the second question is, what's the minimum ACD, or the anterior chamber depth, for sulcus and add-on lens? The company recommends minimum 3 millimeter. My personal safety is about 3.5. So I would do a biometry measurement on a pseudophakic eye, and before I would consider doing a sulcus add-on lens. And again, these sulcus add-on lenses are not for minor refractive outcome surprises like 0.5 or 1 diopter. I'm really talking about, in the range where they're getting anisometropia that they can't, tolerate, something in the range of, at least, 2.5 or 3 or more. And those are the ones that, a surgical option would be possible if they cannot tolerate things like contact lenses. Obviously, elderly patients in their 60s, 70s, 80s, 90s, who's never worn contact lenses before, asking them to go on contact lenses is quite a bit of an ask. So these will be the ideal candidates that, we would consider a sulcus add-on lens for refractive surprises. And the next question is there a special way to refract PH pinhole lenses? Is that what you meant? Yes. So is there a special way to refract, pinhole lenses? The answer is, you can't rely on the autorefractor because they will not give you the answer. It might actually give you error when you try to autorefract, because that beam that shoots right through the pupil gets blocked by the autorefractor. With pinhole lenses, the way to refract them is actually to push the plus, because the pinhole effect actually gives you that, the myopic vision. And you can quite easily sort of, over minus these patients with pinhole. So in some ways, it's quite similar to how you would normally refract patients, who have had something like the Vivity lens. You kind of have to push the plus. And one of the things about the pinhole lens is that if you were to do a corneal topography, on these patients, they may have, 1 diopter or 1.5 diopter of corneal astigmatism. And the good thing about the pinhole lens refraction is, you almost never had to correct the astigmatism because the pinhole corrects it for you.
Well, thank you very much, everyone. So we finished exactly at 7 p.m. today. And we would love to hear your feedback. So please look out for email from us to ask for your feedback about what you want to hear next time. And if you're interested to get a copy of the presentation that we have there, please make sure you put your registrations under this link. And yeah, looking forward to see all of you in future events. And remember, if you need to contact our speaker we will share their email address, and Dr. Hong is reachable on Oculus and Ernst as well. Right, looking forward to seeing you all in future event. Thank you.